is the hospital clinic, and in this European Lupus conference I have a lecture on the management of refractory antiphospholipid syndrome. The antiphospholipid syndrome, as probably you are aware, are systemic autoimmune disease where thrombosis, pregnancy morbidity, and some additional manifestations are the main clinical features. These, together with the presence of antiphospholipid antibodies, the so-called lupus anticoagulant, the anticoagulants antibodies, and the anti-beta 2 glycoprotein 1 antibodies. We now do for patients with antiphospholipid antibodies several approaches. We approach those with antiphospholipid antibodies, but have never had a thrombotic event, providing primary thromboprophylaxis. And then those patients who have suffered already a thrombotic event, we give a secondary thromboprophylaxis. And then there is the management of patients with obstetric manifestations in order to prevent further obstetric events. And finally, there is a very severe form of the antiphospholipid syndrome, patients who develop multiple thrombotic events in just a few days or a week, involving 3 or more organs, and usually producing thrombosis in the microcirculation that leads to failure of the organ, renal failure, liver failure, cardiac failure, respiratory failure, and so on. This is what we call the catastrophic antiphospholipid syndrome. Well, in this lecture, I overview the management of the refractory cases in these 4 settings. For primary thromboprophylaxis, usually we prescribe low-dose aspirin. Low-dose aspirin is an antiplatelet therapy that produces some level of antithrombotic effects, and this prevents the development of thrombosis in many patients that are just asymptomatic carriers of antiphospholipid antibodies. But there are patients that even with low-dose aspirins develop a thrombotic event. For these cases, it was speculated that probably adding anticoagulants, usually at low INR, usually we prescribe anticoagulants at an INR between 2 and 3. In this case, we postulated that an INR around 1.5 would be also more protective against thrombosis. But we performed a trial, so the Lupus trial, and unfortunately we didn't demonstrate a superior efficacy of aspirin, low-dose aspirin plus anticoagulants at the low INR. By contrast, we demonstrated higher risk of hemorrhages in patients that receive oral anticoagulants. So far, just low-dose aspirin. For those patients who presented already a thrombotic event, in order to perform what we call the secondary thromboprophylaxis, we usually prescribe oral anticoagulants at an INR between 2 and 3. But still there are some patients who present recurrence of thrombosis. Especially the higher risk is in those who presented arterial thrombosis. Some of them present another thrombosis, recurrence of this thrombosis. So for these cases, we believe that we must do something else. One option was probably to introduce the direct oral anticoagulants, but unfortunately we performed a trial comparing one of these direct oral anticoagulants, rivaroxaban, versus oral anticoagulants, and unfortunately those patients who were on rivaroxaban had an excess of arterial thrombosis. So at this moment we cannot recommend the use of direct oral anticoagulants in these patients with antiphospholipid syndrome, especially in those who present triple positivity for antiphospholipid antibodies. So at this moment, usually what we do in patients with recurrence of thrombosis is to add either low-dose aspirin or statins or hydroxychloroquine, which has been demonstrated to have also antithrombotic properties. Additionally, in some cases, it is possible to use rituximab, the CD20 biological therapy that could be effective in some of these refractory cases. Regarding the other setting, regarding the obstetric antiphospholipid syndrome, we usually prescribe low-dose aspirin alone in combination with low molecular weight heparin in order to prevent further obstetric morbidity, fetal losses or abortions. But still there are around 20% of the patients who present recurrent morbidity, obstetric morbidity. For these cases, it has been speculated that the beneficial effect of adding hydroxychloroquine, for instance 400 milligrams preconceptionally, adding low-dose steroids, 10 to 15 milligrams during the first trimester of the pregnancy. Also the use of immunoglobulins, intravenous immunoglobulins or plasma exchange, and also the use of TNF-alpha inhibitors, for instance, artemisumab. There are nice studies that demonstrate the efficacy of TNF-alpha inhibitors to prevent further obstetric morbidity problems in these patients. And finally, last but not least, the catastrophic antiphospholipid syndrome. For the catastrophic antiphospholipid syndrome, we use what we call the triple therapy. It's anticoagulation plus steroids, high-dose steroids, plus either intravenous immunoglobulins and or plasma exchange. With this triple therapy, we managed to decrease by 50%, nearly 50%, the mortality in the acute catastrophic event. But still, there are around 30% of the patients who currently die in the acute event. There is also a small percentage of patients who recover from the acute event but present a relapse of the catastrophic event a few weeks or few months later. So for these patients, the so-called refractory catastrophic antiphospholipid syndrome, we need something else. And there are two biological therapies that we have analyzed. On one side, rituximab, that using data from the CAPS registry, we have demonstrated that rituximab could be effective in approximately 70% of these refractory cases. And on the other side is eculizumab, which is anti-complement therapy, therapy that has been used and is approved for other conditions that have some similarities with the catastrophic antiphospholipid syndrome, and also some patients with catastrophic antiphospholipid syndrome have received eculizumab, and again, 2/3 of them have improved. So this could be another option for the refractory cases. So these were the main 4 scenarios that we analyzed in this lecture, in this European Congress of Lupus. Thank you very much.